This first part of the lecture will address rehabilitation of the elbow and forearm. Following along in your notes, you'll see that there's just some general guidelines to elbow rehab. First, we'll address the joint stresses at the elbow. Often seen with acceleration phase during throwing, we have lateral compressive forces and medial distraction forces at the elbow. Because of these forces on the lateral elbow, because of the stresses, we'll see changes like articular damage, osteophytes, things that are related to bone and compression. And then on the medial side, we'll see things that relate more to the tension. It's like neuritis, tendonitis, sprains, or strains. During the deceleration phase of throwing, there is often a high demand on what we call the 3Bs, the biceps, brachioradialis, and brachialis. So depending on where the pain is at the elbow, it sometimes will be because of different stresses, and then different conditions will develop. There's a unique structure at the elbow. There's a high degree of congruency of the joint, which you can see a little bit in this picture. And because of that high congruency, it's a very stable joint. Muscles traverse all around the joint. I don't have a picture for that, but the brachialis inserts on the anterior superior joint capsule. And we often see adhesion problems at this area, which will occur oftentimes if the elbow is immobilized for greater than 2 weeks. So we want to keep immobilization really limited at the elbow. And then the anterior capsule is very thin and can be damaged with aggressive stretching. So as we move on to rehabilitation in the elbow, specifically talking first about flexibility. So we want a prevention of loss of motion. A lot of times post-surgically there are machines called continuous passive motion machines in order to get early mobilization used. And then, as I said earlier, we have an abbreviated immobilization period as appropriate. B, regaining loss of motion. We want to utilize short, active stretches early, but later we'll have more prolonged stretches when the collagen matures. We have to remember to be very cautious with passive stretches because of the thin anterior capsule. And a long, low load stretching is best. Common stretches that we'll see in the elbow is we'll utilize pronation and supination. This is an example there of a picture of him stretching with supination. There's an extensor stretch that's offered in the book, a self-stretch for the supinator, a pronator self-stretch, of course some assisted stretches as well. As far as joint mobilization, the ulnohumeral joint is a concave on a convex joint, so the roll and the glide are going to be the same. And then at the radioulnar joint, we have a convex on a concave, so that's the radial head on the ulnar notch. And so those are going to be, the roll and the glide will be opposite. So if I'm trying to increase supination, my glide will move from posterior to anterior of the radius on the ulna. So we'll practice those in class as well. Capsular pattern at the elbow is flexion is more limited than extension. Pronation and supination are equally limited. If we want to use mild grades or low grades if the elbow is really inflamed, and postpone those aggressive grades until that's under control. We'll start with the loose pack position with grades 1 and 2 being applied in the initial applications. Loose pack positions, review the ulnohumeral joint is loose packed at 7 degrees of flexion and 10 degrees of supination, just like you can see in the picture here. And the radioulnar joint, loose packed is 70 degrees of elbow flexion and 35 degrees of supination. Closed packed position at the ulnohumeral joint is full extension, and at the radioulnar joint is full pronation or full supination, either one of those. Mobilization is used a lot of distraction at the elbow, as shown in this picture. Here's a ventral glide, working on pronation and supination with the dorsal and ventral glides. And we'll review those in our lab. On pages 750 to 754 are an example of a lot of strengthening exercises. In your notes it says we'll start with isometrics, goes in the line there, and we'll progress to isotonics in a straight plane and then diagonal plane motions. And that we've seen in other rehabilitations, so that's not unusual. So here's some ideas for elbow flexion exercises and elbow extension. And then we can incorporate some shoulder as well with the shoulder extension and then elbow extension and pronation and supination. The book talks about some ideas for plyometrics, which are very similar to the shoulder joint, and then moves into shoulder carryover exercises, so combining some of the elbow and the shoulder exercises as they most often work in a single chain. Functional activities need to start with a warm-up and also have a cool down. They should begin overhead progressions with easy activities at a short distance, force and speeds, and then gradually increase. Only one, and that goes in the line on your notes, only one component at a time, and no more often than every third exercise session. That's because if somebody gets inflamed, we might be able to track down what the offending exercise is and change it. If pain is present, we'll return to the previous level of exercise for 3 days before we progress on. So that's the general outline. Let's move into specific conditions at the elbow. The first one is epicondylitis, lateral epicondylitis, otherwise known as tennis elbow, and often frequently involves the extensor carpi radialis brevis. So that's the one that you should be real familiar with. Medial epicondylitis is golfer's elbow. Oops, there's extensor carpi radialis brevis, going down to the third base of the third metacarpal, which will make a difference on how we stretch for lateral epicondylitis, because we want to isolate out this muscle at the third metacarpal. Medial epicondylitis, otherwise known as golfer's elbow, and involves the flexors of the wrist. The causes can be multifactorial, cumulative trauma because of improper technique or equipment. So the treatment is primarily to find the cause of the problem, which will probably lead to starting with treating the inflammation with modalities and massage. Counterforce braces are oftentimes used. They look like this, or you can use tape. The flexi tape works fairly well for that. Flexibility is the first focus then as far as actual exercises, doing a lot of joint mobs and active range of motion stretches. And then the strengthening, the first strengthening exercise we give is eccentrics. Sometimes we don't work into eccentrics until later. With epicondylitis, in fact, many of the tendinitises, we'll start with eccentric exercises and then progress to the concentric and eccentric. So in your notes, I've highlighted an eccentric exercise program for epicondylitis. It's also on table 15.5 in your book. And it shows the first week of progression where you start with slow eccentric exercises. We're going to assume that it's lateral epicondylitis, so slow eccentric exercises for the extensor carpi radialis brevis. 3 sets of 15, second day the same. Third and fourth day we just go at a moderate speed, and then days 5 through 7 are fast speed because that increases the forces that are being utilized. If the patient handles that all right, starting on week 2, we'll continue with the 3 by 15 reps, but we're going to increase and the weight and start with 1 pound, and then the reps will all be done at a fast pace. Increasing resistance every 4 to 7 days if there's no pain. If they do have pain, you have to stop and hold at the previous pain-free level for about 3 days before you can progress on. It's a really common eccentric exercise program and is highly recommended for lateral epicondylitis. Occasionally these don't get better and somebody might have to go in for surgery, and for surgery they will do an extensor carpi radialis brevis debridement. So they come up here into the tendon and they debride any calcifications. In real severe cases, they could have to detach this because it's so frayed and there's so much pain with use of that muscle. I've only seen that once in rehab, but usually it's a debridement of this tendon. And then they come into therapy, and full range of motion should be achieved in about 3 weeks. And AROM is started early. If it hurts too much to do the active range of motion, then they aren't to do that yet. So it's primarily active range of motion. Full rehab takes about 5 to 6 months. So that's a fairly long one, but again, you don't see that post-operatively very long or very often. Little leaguer's elbow, it causes thought to be curves and breaking pitches, which cause an increased demand on wrist flexion and pronation, and an inflammation at the medial epicondyle epiphyseal plate. Usually conditioning in the thrower, which are young athletes, is poor. There's no warm-ups. There's too much pitching going on. They start to complain of the symptoms of medial elbow pain, pain with finger and wrist extension, and pain with resisted finger and wrist flexion. And those are usually strong indicators that we're getting some problems with that medial elbow, almost like an avulsion at the epiphyseal plate. Treatment starts off being with rest and ice. And the important thing is to remember that there is no passive range of motion done. It's only comfortable active range of motion, so whatever they can handle. And when they get full active range of motion, then you progress into low weights for some strengthening. Again, it's really similar to an avulsion fracture. Here's a picture of someone with little leaguer's elbow, and you can see that it looks like a fracture on x-ray, but that's the medial epicondyle epiphyseal plate. Next on your notes, and I don't have a picture with this, is sprains. Oftentimes it's a hyperextension sprain, and in that case, because that anterior capsule is so thin, you need to strengthen the muscles that cross that area, which would be the 3 Bs, biceps brachialis and brachioradialis, as well as the supinator, and avoid pain as much as possible. The flexor carpi ulnaris muscle is a major stabilizer of the anterior and medial elbow, so you need to be careful with flexor carpi ulnaris strengthening. We don't want to inflame or aggravate it and cause more problems. It's a pretty important muscle at the elbow with the hyperextension sprain. So strengthening the 3 Bs, the supinator, and the flexor carpi ulnaris. Medial collateral ligament sprains, we're going to focus on strengthening the biceps, the pronator, and the wrist flexors. Again, concentrating on the flexor carpi ulnaris and making sure not to aggravate that muscle. So in order to emphasize that, we do wrist flexion with ulnar deviation at the same time. Flexor carpi ulnaris picture right there, and you can see how it attaches right into the base of the 4th and the 5th metacarpals, causing ulnar deviation. Ulnar nerve damage, often because of overhead throwing with a decrease in external rotation at the shoulder. So if I've got a thrower and they don't have full external rotation, they'll tend to throw that elbow into more of a valgus force and cause some damage of the ulnar nerve. Treatment is to decrease pain and inflammation, so rest. We might want to do some joint mobs at the elbow or the shoulder and get some more external rotation out of the shoulder. Can also do strengthening then of the shoulder, the elbow, and the forearm in order to support the joint. In your notes it says a double asterisk there, make sure that you remember that shoulder external rotation will increase valgus force at the elbow. So we're very careful with aggressive shoulder external rotation stretching because it could flare up the elbow. Dislocated elbow, you'll see those occasionally if you work in sports medicine. 4 to 5 months of rehab. They're first put in a splint post relocation for about 2 to 3 days. And during that time, you start having them work on shoulder and wrist rehab, making sure that they maintain range of motion there. There is no passive range of motion performed for fear of dislocating that again. However, at 6 weeks post-op or post-dislocation, if they still don't have full range of motion, you can start some joint mobs. Strengthening primarily of the elbow flexors, and you can see why, because that usually the humerus comes anterior and can rip through tissue on the anterior portion of the elbow, and so strengthening of the elbow flexors is very important. They may need to be braced with a hyperextension brace later, and again 4 to 5 months for full return to participation. So I do have a video. We had an athlete one year that had a dislocation at the soccer field, and his buddies, we splinted him, and a couple of his teammates took him into the ER and took a video of them. Took a video of them relocating this joint. So we have a video here. We'll see. So he's in the ER.
So take your. Yep, there we go. Yeah. Okay. Yep.
He's under the influence of quite a few drugs here.
Good. Let's bring it over.
Good job, Chris. Guys. Up there.
And up and bang. Yeah, that's good. Okay. Yeah, no, you guys are like, see ya. There's the stock in that.
Man, that is quick. Holy cow.
Yeah, I got water.
Yeah, that, holy cow, man.
You guys want to lift that on?
Oh, it's quick. The meds with the arm.
Yeah. Chill. I feel like I'm in Washington.
Filter
It's gonna go in.
Okay. Shoot. Feel a little pain in the top, but you're already moving away more short.
Alright.
It's like 2 o'clock every day right now.
2 o'clock every day? What happens at 2 o'clock every day?
Nap time.
Coach missed out.
Like not even nervous about the fan right now.
You seem pretty comfortable now.
It's good.
That's crazy how fast that works. I'm impressed.
I
I
can't
don't remember this, but I remember the moment here. But
Oh, you'll remember it.
Anyway, this can be kind of entertaining sometimes. So, okay, and then the last thing on your notes is elbow arthroscopy. That's usually performed for debridement of loose bodies. For rehab on this, we start with active range of motion as well as pain-free passive range of motion, and it should be full within about 7 days. Strengthening can start right away with ball squeezes, so we have good circulation and movement of the hand and wrist. Full recovery after an arthroscopy is usually about 2 to 3 months. Treating the symptoms, so if we have lack of range of motion, we're addressing that right away and then working on strength. So, okay, that wraps up elbow. Then we're going to move to wrist and hand. So the wrist and hand general principles, the pulley system is on the flexor aspect of the fingers, and then there's a system of 8 pulleys in the hand that contains the flexor tendons, similar to on a fishing rod where it's got little hooks and loops. Okay, so then we have the tendons going in through these, and that's the pulley system to help increase the strength and contain the tendons. Another point for the hand is in regards to edema, and it frequently will accumulate in the dorsum of the hand. Your book has some decent pictures of that, which can impair finger range of motion pretty significantly, as well as function. So implications are that in your notes it says, A, we must reduce edema early. It's helpful to use a measurement gauge of some kind. Circumferential gauges are often used, or you can use a string wrapped around the finger, and then you measure how long the string is or where it ended. But early controlled passive range of motion is also often necessary, and that is often done with splints. And when we're splinting, we need to remember that the position of hand immobilization is like this. So we have just a little bit of extension, little opposition, and flexion in all of the MCP and IP joints. There are 2 general splints that are utilized in the hand: a static hand splint used to restrict range of motion and protect. Usually it's splinted in the functional position, which we already spoke about. And then there are dynamic splints. And dynamic splints will move with the hand or the joint as you gain range of motion. So it's got just low level tensions. Either these are provided by these springs. Sometimes it's a string or pulley system. And these are either tightened manually or they're automatically just like a spring loaded, and so they move as the motion gets better. Precaution for these splints is that they might get pressure sores in certain areas, particularly in the styloid process of the pisiform or the metatarsal heads. All right, so in our rehab, number 1 says decrease edema. How do we do that? Primarily through elevation, compression, massage, and active range of motion. Those are all frequently utilized. Flexibility. We are going to apply mobilization techniques typically in the hand before the joints are stretched. So it's fairly common to work on joint mobs, so we'll address those first here in your notes. We've already talked a little bit about the radioulnar joint at the elbow. There's also a distal radioulnar joint down at the wrist, and that's where we use the anterior and posterior glides in order to improve pronation and supination. Oftentimes they're missing both of those, so we'll glide both posterior and anterior to improve those. At the wrist, we have a convex on a concave surface, so the roll and the glide will be the opposite. And on our MCP and IP joints, the concave on a convex, so roll and the glide will be the same. So be sure to review those as far as how do we improve wrist flexion, extension, or ulnar deviation and ulnar deviation, and we'll be demonstrating those in lab. In regards to stretches, we want to stretch one joint at a time when we're talking about the fingers and wrists. So stretching just here, like this picture shows, we have an extension stretch here with flexion here and neutral here, which would be okay. Or we can do flexion and keep the other 2 joints in neutral, but we wouldn't want to immediately stretch the DIP flexion, the PIP flexion, and the NCP right in flexion. So just one joint at a time. Gliding exercises are often utilized in order to avoid tendon adhesions. In your notes, it talks about here active range of motion of the flexor tendons. So if you're doing rehab, Somebody that has an injury to the flexor tendons, they need to be able to do these three things. And so follow along with your own hand. Extend your MCPs and flex all of your IPs, so kind of like a claw hand. They need to be able to do that. They need to be able to flex the MCPs and the IPs, so a fist, and then flex the MCPs, the PIPs, and keep the IPs or the DIPs extended. So those are goals that need to be reached for range of motion for all the flexor tendons. As far as extensor tendons, we just make sure that they don't have an extensor lag at the joint. So that's just like an extension lag at the knee where passive range of motion is full, but active range of motion is not. So we'll address that in strength. Keep the other joints in neutral and relaxed in order to reduce soft tissue tension. And location of the stretch force, distal portion of the distal arm. So you can see the stretch force is being placed here at the distal area. The book talks oftentimes about the extrinsic and intrinsic muscles. So the extrinsic muscles are muscles that act on a designated region but originate somewhere else. So all these muscles that work to flex the fingers and wrist, but they come from the elbow or originate at the elbow, are considered extrinsic muscles. It might be easier just to remember that if the muscle or muscle tendon crosses the wrist, then you can pretty much say that they're going to be an extrinsic muscle. So in your note it says if there's extrinsic tightness, so tightness of the wrist flexors and extensors, like the ones in these pictures. When we stretch these muscles, we're going to stretch them from distal to proximal. So you'll start with this, like if you're going to stretch your flexor digitorum profundus tendon, you would go into DIP extension, then PIP extension, then MCP extension, and then wrist extension, so distal to proximal. If, however, somebody has intrinsic muscle tightness, and those are muscles that are contained entirely within the hand, so they don't go across the wrist, the interossei, the lumbricals, those are examples of muscles. When we stretch these, when they're tight, you stretch them by flexing your IPs, so flex your IPs, your DIPs and the PIPs, and extend your MCPs. So extending the MCPs and flexing the IPs will stretch the intrinsic muscles. So depending on your target muscle, you'd stretch them a different way. Tendon gliding must be possible before resistive exercises can begin. Otherwise, you don't get a smooth movement with your strengthening exercises. In your notes, it goes through the differences between flexor and extensor tendons just briefly. The majority of your flexor tendons are in a sheath because the extensors are extrasynovial. Flexors are in this strong pulley system. Extensors don't have a pulley. The flexion strength is greater than extension strength. Tendons are flatter and thinner. A loss of extensor tendon mobility is actually more debilitating than flexor tendon loss. So it's really important to get extension or extender tendons moving. And the loss of extensor tendon mobility more severely impacts intrinsic muscle function. So those muscles will end up becoming atrophied and weak as well. Moving on to strengthening. In your notes, an emphasis will be placed on concentric rather than eccentric. That's just how they're utilized more. And it's very important that you know that somebody needs to be able to extend their wrist and work their fingers in flexion. So be careful that you don't give strengthening exercises with the wrist in neutral or a flexed position, because functionally they have to extend their wrist in order to make a fist. So that's very important. Again, the book has several examples on pages 809 to 817. Let's see. Get caught up on a few pictures here. So here's the extrinsic finger extension stretch we said from distal to proximal a little bit ago. Intrinsic stretch, MCPs are extended, IPs are flexed. You could also tape down to get range of motion. And then the book talks a lot about the arrangement of the carpal bones, and then there's some pictures, and we'll review these in class. but you should be pretty familiar. So resistance exercises, here's just a few examples for extension. Note that they're stabilized proximal, okay, for flexion extension, radial ulnar deviation. This would be very difficult, a little higher level. There's theraputty and wrist exercises that can be used. Different colors of putty has different resistance. We don't have a full supply of putty. Oftentimes I'll start somebody with rubber bands, different thicknesses, and have them do some exercises. Here's some examples. And then I might order some theraputty later if we utilize it. Here's extension lag exercises, so ones that they can work on to get that terminal extension of their, typically their DIPs, maybe their PIPs or MCPs is in this picture, working on the extensor lag with a weighted ball. And they're isolating out just a particular tendon and working on just one joint. All right, so in general, we said we're going to preserve the range of motion, especially in the PIPs, pretty important. And if you're not sure why somebody isn't getting their range of motion back, then don't be afraid to go ahead and get an x-ray. So moving into our rehabilitation or specific injuries. First of all is fractures. And it's generally immobilized in a position such that the ligaments are placed on stretch in order to reduce the risk of contracture. Most important is to preserve range of motion. The PIP often is stiff for months or years after an injury. So that joint needs to be on a little bit of stretch. After fracture, immobilization is maintained for 2 to 3 weeks unless the fracture is unstable, displaced, or comminuted, in which case they'll probably have surgery. Or for an open reduction internal fixation to pin things together. Immobilization is used for only as many joints as is necessary in order to stabilize the fracture. All right. Here's some of the more common ones. A Smith's fracture is the distal radial fracture that displaces in the palmar direction. Okay. A Colles fracture is a distal radial fracture that displaces dorsally. So this piece went dorsal. Okay, these are now these pretty much are considered surgical candidates. The Barton fracture is a fracture of, again, the distal radius. But there's also a subluxation in a Barton's fracture. So we have a fracture and then it subluxes. The wrist subluxes. So program considerations and progression. They're probably a surgical candidate, and then when they come out, then they'll have to work on range of motion, but we have to decrease edema oftentimes. And there's a tape called Coban wrap that has a little extra stretchy to it and then kind of compresses back, which is used often times. So just be familiar with that. Isotoner gloves are a particular brand of glove that we would recommend in rehab if somebody had a fair amount of edema in their hand. So, things that they need to be able to do in rehab. So in your notes it says should be able to IP flex and MCP extend. That's the same as your intrinsic stretching. IP extend and MC flex, and then IP flex and MCP flex in order to get a fist. And then strengthening always starts with these guys with isometrics and fairly quickly moving into isotonics and functional activities. In regards to other fractures, the carpals and metacarpal fractures, common one, the scaphoid fracture, of course, is the most commonest one in the of the wrist bones to be fractured and of the carpal bones. So that's right down in here. That's the trapezium here, and that's the scaphoid, and has a poor blood supply. And then the Bennett's fracture is a fracture of the first metacarpal. So right here. The important thing with both of these is that we don't get a restriction of the thumb's web space. So the thumb active range of motion starts fairly quickly when the fracture has healed. That's the main thing to remember about those two. Phalangeal fractures. A proximal fracture is most likely versus the middle phalanx fracture. However, with the middle one, oftentimes it will result in displacement and instability because of this extensor tendon slip. Causes a displacement because this is so tight. Adhesions are often possible and can complicate it, so they're rarely immobilized more than 4 weeks of total time. And then a PIP joint usually dislocates dorsally. That's the middle phalanx relative to the proximal phalanx. So it will dislocate dorsally. And then a note about mallet finger, which you see a lot in sports fractures, is an avulsion of the extensor tendon off of here. So the tendon pops off of here. So the DIP can't extend. So they'll put it in a splint and to approximate the avulsion, so get the bone approximated back down to the distal phalanx so that it will heal. This is called a no-peak splint. They're kept in this for 6 to 8 weeks full time. You have to be a little careful that skin doesn't break down here. But taking this splint off once and bending it could actually re-tear this, and they have to start those 6 to 8 weeks all over again. So if somebody has this splint and you're working with them, it's really important that they're diligent in keeping it on. The PIP, just a note here. I guess we aren't to dislocations yet. So we'll come back to that. I did have it. Oh, there's my picture. Okay, finger dislocations. Dislocation is just a more severe sprain. It often occurs in the IP joints, especially the PIP, as in the picture here. If it's a sprain, it's called, we often call it a jammed finger in the layman's terms, but it's actually a finger sprain. Unstable dislocations can require surgical repair. With a stable dislocation, the finger is immobilized. With the PIP joint, because that's the most often one, in 20 to 30 degrees of flexion for 1 to 2 weeks. So that's important to know, 20 to 30 degrees of flexion for 1 to 2 weeks, but not more than 30 degrees because the PIP joint can acquire a flexion contracture, so then it has difficulty straightening out. And so now we have an extra problem. So it's important to remember that 20 to 30 degrees of splinting. Okay. Some overuse injuries, carpal tunnel syndrome. Not great success in rehab in treating these. There's a compression, of course, of the carpal tunnel. So how do we decompress that or get some space in there? It might be helpful to use night splints so that they don't go into full flexion and cause compression there. That might be helpful. Modalities such as ultrasound or heat to try to stretch out this flexor retinaculum on the roof here, that might be helpful. Gliding exercises where they just go into wrist flexion and extension could be helpful. Again, there's not a lot of great rehab solutions. If it gets really bad, they'll do a surgery now. They used to go in and open cut this. They do it by laser now. And then they come into rehab to work on desensitization of the area and soft tissue mobilization as it kind of heals over. The last one in your notes is Dacre-Vanes syndrome, which you see occasionally in the sports medicine. It's an inflammation of the abductor pollicis longus and extensor pollicis longus brevis. The extensor pollicis brevis in these tendon sheaths, and they get inflamed. And so we try to reduce the inflammation of these with modalities and splinting with the wrist in extension and the thumb in abduction and the MCP in 10 degrees of flexion. So we got a little bit of a stretch on here, but not a lot as these tendons, this sheath or the synovium swelling decreases and the tendon calms down. But as far as rehab, then it's just doing some gentle stretches into ulnar deviation after they come out of the splint and working the strength back. So, then you at the end here you have a case study, a golfer with lateral epicondylitis. So I'd like you to review that, come up with an exercise plan, what you want to do with this athlete, and bring that to class with you, and we'll practice the recommended rehab techniques as well as going over some of the other techniques that would not be applicable for this. So thanks.